Okay, good afternoon.
Good afternoon, Doc.
Okay. So for this afternoon, we are going to take up about local anesthetics. So local anesthesia is the condition that results when sensory transmission from a local area of the body to the CNS is blocked. While your local anesthetics are drugs that block the generation and propagation of impulses in excitable tissues, notably your spinal cord, spinal nerve roots, and peripheral nerves. So your local anesthetic constitute a group of chemically similar agents that block the sodium channels of excitable membranes. So the target of your local anesthetic is the sodium channel. So local anesthetics can be administered by injection in the target area or by topical application. Anesthetic effect can be restricted to a localized area. So when given intravenously, local anesthetics have effects on other tissues. So this is the structural formula or your chemical structure of your local anesthetics. So your local anesthetic molecule consists of 3 building blocks. You have the aromatic group or the benzene ring or the lipophilic portion of your local anesthetic and the amine group or the hydrophilic portion of your local anesthetic. Your aromatic group or your lipophilic portion of your local anesthetic is joined to your hydrophilic group, which is the amine group, by an intermediate chain. So your intermediate chain could either be an amide linkage or an ester linkage. So the intermediate chain that would connect the lipophilic head of your local anesthetic to the hydrophilic tail contains an amide or an ester linkage, thus subdividing the clinical useful local anesthetic into amino esters and amino amides. So the intermediate chain would determine the classification of your local anesthetic. Local anesthetic is classified either an ester or an amide, depending on what is the intermediate chain. So local anesthetics is the group of your local anesthetics. You have the esters and the amides. So among the esters, you have tetracaine, procaine, chloroprocaine, cocaine. And your amides, there are a number of them. You have the long-acting, which is bupivacaine and ropivacaine. The intermediate-acting, you have lidocaine, mepivacaine, prilocaine. So these are your local anesthetics. So, pharmacokinetics of your local anesthetic. Many shorter acting local anesthetic are readily absorbed into the blood from the injection site after administration. So duration of action of your local anesthetic is therefore limited unless blood flow to the area is reduced. By the way, the duration of action of your local anesthetic would depend on the rate of absorption of your local anesthetic. If you have a rapid absorption of your local anesthetic, it will give you a shorter duration of action, while a shorter duration of local anesthetic would result on a delayed absorption. So that Systemic absorption of your local anesthetic determines the duration of your local anesthetic. Decreased systemic absorption of your local anesthetic provides greater margin of safety in clinical practice. So that if you have a rapid absorption of your local anesthetic, probably it would lead you to overdosage or toxic levels of your anesthetic levels, because it would result to a very high peak plasma level of your local anesthetic. So that decreased systemic local anesthetic absorption provides greater margin of safety in clinical practice. So you do not want to have a rapid absorption of your local anesthetic, because it would lead you to a higher plasma level, resulting to local anesthetic systemic toxicity, being abbreviated as your LAST, LAST, local anesthetic systemic toxicity. So, your local anesthetic can be accomplished by administration of a vasoconstrictor, usually an alpha agonist sympathomimetic, like for example, your ephedrine or your epinephrine. So local anesthetic can be administered with a vasoconstrictor, usually epinephrine. And the purpose of your vasoconstrictor is to delay the absorption of your local anesthetic, thus preventing toxicity from your local anesthetic. That is the purpose when you administer a vasoconstrictor. Since it produces vasoconstriction, it would delay the absorption of your local anesthetic, thus providing a greater margin of safety. Cocaine has an intrinsic sympathomimetic action due to inhibition of norepinephrine reuptake into nerve terminals. So cocaine, one of the esters group of local anesthetic, is the first local anesthetic that has been used clinically. So your local anesthetic, the pharmacology of your local anesthetic, they are vasodilator. But the only local anesthetic with a vasoconstrictor property is cocaine, due to its inhibition of norepinephrine reuptake into the nerve terminals. So the longer-acting agents are also dependent on the co-administration, less dependent on the co-administration of your vasoconstrictors. Your vasoconstrictors like epinephrine becomes beneficial if you are using a local anesthetic that is short or intermediate duration of action. While the longer-acting local anesthetic, your vasoconstrictor is less of importance. Why? Because the local anesthetic in itself, being longer in duration of action, usually it has a delayed onset effect or delayed absorption. So surface activity, ability to reach superficial nerves when applied to the surface of mucous membranes. So local anesthetic can be administered topically as a cream, as a spray. They can be administered into the mucous membrane either through preparation of a cream or a spray. So you have her pharmacologic effects of your local anesthetic. So your local anesthetic would depend on differential sensitivity of your local anesthetic to your nerves would depend on fiber diameter, degree of myelination, physiologic firing rate, and anatomic location. So fiber diameter, the smaller fibers are blocked more easily. Myelination, if the nerve is myelinated, they are blocked more easily. Physiologic firing rate, activated pain fibers fire rapidly. Anatomic location, fibers located in the periphery of a thick bundle are blocked sooner. Meaning to say, if you have a nerve bundle fiber, the one that is black first is at the periphery or at the mantle. That is the proximal structure. They are the outermost, being at the periphery. They are the one that is black first. So that conduction blockade proceeds from the outermost, that is the mantle, to the innermost or the core portion, which is the distal structure, along a concentration gradient. So other tissues, most have weak blocking effects on skeletal muscle neuromuscular transmission. Mood elevation induced by cocaine reflects action on dopamine or other amine-mediated synaptic transmission in the CNS rather than a local anesthetic action on membranes. So cocaine is no longer used today because, as you know, because of the untoward effects of your cocaine. It has the potential to cause addiction, abuse. So it is no longer used today, but it is the first local anesthetic that has been used clinically. So the usual route of administration include topical application, injection in the vicinity of the peripheral nerve endings, major nerve trunks, like your brachial plexus block, injection into the epidural or subarachnoid space surrounding the spinal cord. This is now, when you give your local anesthetic into the epidural space, then you will have epidural anesthesia. And if you give this local anesthetic into the subarachnoid space, it is known as your spinal anesthesia. So you have clinical block characteristics of your local anesthetic. There is generally an orderly evolution of block components, beginning with sympathetic transmission and progressing to temperature, pain, light touch, and finally motor block. This is known as your differential block brought about by your local anesthetic. Differential blockade, this describes the blockade of a component of a peripheral nerve that proceeds from different rates. So the first one that is being blocked by your local anesthetic is your sympathetics or your autonomics. The second is your sensory block, meaning to say your pinprick sensation, your touch, temperature discrimination. And the last one that is being blocked is your motor function that would result to your skeletal muscle paralysis. This is differential block because if you want only that you are going to block your sensory, you give a lesser concentration of your local anesthetic. But when you want relaxation, then you want to have a motor block, then you give higher concentration of your local anesthetic. And there are certain local anesthetic that is used for this purpose. Not all anesthetics are being used for this purpose of differential blockade. We'll have to mention it later. So, onset of peripheral block is more variable, and proximal motor weakness may precede onset of more distal sensory loss. So, clinical use of your local anesthetic, commonly used for minor surgical procedures, often in combination with vasoconstrictors such as epinephrine. So, by the way, your uses of your local anesthetic, the first one is used for minor surgical procedure because local anesthetics are used to provide regional anesthesia for surgery. So, Another use of your local anesthetic is to provide post-operative analgesia for painful surgical procedures. So it is used intraoperatively to provide anesthesia, and it could be used post-operatively for post-operative analgesia. And the other thing, attenuate the pressure response to tracheal intubation, decrease coughing during intubation and extubation. When you say attenuate pressure response to tracheal intubation, when you do endotracheal intubation, I hope you have already an idea what is endotracheal intubation. You place an endotracheal tube into the trachea for maintenance of your general anesthesia. So when you intubate your patient, there is a so-called pressure response, meaning to say that your endotracheal intubation procedure tends to stimulate your sympathetics. So when you stimulate your sympathetics, you expect an increase in your blood pressure, an increase in your heart rate. And in this situation, this is not advisable if you have a patient who is hypertensive and a patient who has myocardial ischemia, because they cannot tolerate an increase in your blood pressure and increase in your heart rate. So what you do is before you intubate your patient, you give lidocaine to attenuate the pressure response brought about by tracheal intubation. Another use of your local anesthetic, most especially lidocaine, is its anti-arrhythmic effect. So lidocaine, aside from being a local anesthetic, it is used for its anti-arrhythmic effect. So these are the uses of your local anesthetic, clinical uses of your local anesthetic. So onset of action may be accelerated by the addition of sodium bicarbonate. So sodium bicarbonate enhances or accelerates the onset of action of your local anesthetic. So meaning to say, when you alkalinize your local anesthetic, it would accelerate its onset of effect. Opposite to this is in the presence of acidosis. Acidosis antagonize local anesthetic block, so that in an acidic environment, your local anesthetic tends to be ineffective. So that is why in the presence of abscess, in the presence of infection, wherein the environment is said to be acidic, your local anesthetic is ineffective. So that is why the dentist, if you have an abscess, if you have an infection, the dentist will not extract, because the local anesthetic is said to be ineffective. So that the dentist will give or will prescribe antibiotic to subside the infection, so that there will be no infection which favors an acidic environment that would lead to ineffectivity of your local anesthetic. So opposite to that, sodium bicarbonate, so the onset of action is accelerated by the addition of your sodium bicarbonate. Articaine has the fastest onset of action. Also used in spinal anesthesia and to produce autonomic blockade in ischemic condition. So your local anesthetic, for example, when we have mentioned previously that when sodium, when pentothal sodium or when thiopental extravasate, meaning to say it gets out from the vein, so when it extravasates, it causes excruciating pain, it causes tissue damage. So one of the treatment is lidocaine. So when you give lidocaine in these cases, so it would produce blockade in ischemic condition, because when the sodium pentothal or thiopental extravasate, it causes intense vasoconstriction. So your local anesthetic, as we have said, by vasodilator. So the vasoconstrictor effect of your thiopental would tend to produce the intense vasoconstriction would lead to gangrene formation. So to counteract this, you give lidocaine, because lidocaine is a vasodilator. It would counteract the vasoconstrictor effect from your thiopental. Slow epidural infusion at low concentration has been used successfully for post-operative analgesia. So epidural infusion of your local anesthetic can provide you post-operative analgesia. Repeated epidural injection in anesthetic doses may lead to tachyphylaxis. Tachyphylaxis, this is tolerance to a drug, as acute tolerance to a drug as a result of giving the drug repeatedly. So repeated doses, there are some drugs that when they are given repeatedly, they produce acute tolerance. That is the meaning of tachyphylaxis. So we come to toxicity of your local anesthetic. So when we say toxicity from your local anesthetic, I have said it is being abbreviated as LAST, LAST, local anesthetic systemic toxicity. So toxicity from your local anesthetic in general. So local anesthetic toxicity derives from two distinct processes. One would be the systemic effects following inadvertent intravascular injection or absorption of the local anesthetic from the site of administration. So second one is neurotoxicity resulting from local anesthetic effects produced by direct contact with neural elements. So we come to systemic effects. So systemic toxicity, the name implies local anesthetic systemic toxicity. So systemic toxicity from your local anesthetic is brought about by an elevated plasma local anesthetic level. That is the main reason why you have toxicity from your local anesthetic. Systemic toxicity from your local anesthetic is being brought about by an elevated plasma local anesthetic level. When do you have an elevated plasma local anesthetic level? It is due to the intravascular injection of your local anesthetic. So when you give your local anesthetic directly into the blood, there would be a rapid absorption and there would be an elevated plasma level of your local anesthetic. That is one way wherein you will have an elevated plasma local anesthetic level. And the second, of course, it is due to the rapid absorption of your local anesthetic. Remember, when you give a drug intravenously or intravascularly, you expect to have a rapid absorption of your local anesthetic. So rapid absorption of your local anesthetic would result to an elevated plasma level of your local anesthetic. So for any given site of administration, even if whatever be the administration of your drug, for any given site of administration, the greater the total dose of your local anesthetic, the greater the extent of systemic absorption and peak plasma level. So aside from injecting your local anesthetic intravascularly, if you give a very high dose or concentration of your local anesthetic, it would also result to a higher or an elevated plasma local anesthetic level. So that is why when you give your local anesthetic, the simple maneuver of aspirating before you inject your local anesthetic, just to be assured that you are not inside a blood vessel, is a very good practice. When you give your local anesthetic, even if you give it in local infiltration, it is advisable to usually aspirate before you give your local anesthetic. So that if you are able to aspirate blood, then you do not continue the giving of your local anesthetic for sure, because you are injecting your local anesthetic intravascularly, and you will be having an elevated plasma level. That is the same also when you give your local anesthetic into a very vascular area. Because when you give your drug into vascular, highly vascular area, you will expect rapid absorption because of vascularity from that area. For example, your mucous membrane. When you give your topical spray, do not give it as left and right as you want it to, because you will, for all you know, you will be having toxicity from your local anesthetic because your mucous membrane is very vascular. So that when you talk about local anesthetic toxicity, this is very important. Even if you administer your local anesthetic right technique, meaning to say you are not inside the blood vessel, but if you give it in a very high dose, you will result to toxicity. You have given the right dose, but you have not given it in the correct manner that it should be given. So you do not give a higher dose, but you give it intravascularly. The same thing will happen. So that when you give your local anesthetic, you give the minimum effective dose at the right manner, so that you will not resort to local anesthetic toxicity. So, toxicity, what are the organs that is involved in local anesthetic toxicity? There are two organs that is being affected when you have local anesthetic toxicity. You have the CNS and the cardiovascular system. The CNS is more sensitive to the toxic effects of your local anesthetic, while cardiovascular system is more resistant. So that is why the manifestation of local anesthetic toxicity would give you the manifestation, CNS manifestation first, rather than your cardiovascular. So that you can see here, the important toxic effects of most local anesthetics are in the CNS. You have lightheadedness or sedation, restlessness, nystagmus, tonic-clonic convulsions. While severe convulsions now, if there is no intervention to your local anesthetic toxicity, severe convulsion may be followed by coma, now with respiratory and cardiovascular depression. So CNS comes first. It is one that is being involved first by your local anesthetic toxicity, while cardiovascular comes in later. So when you give your local anesthetic, even local infiltration, most especially when you have given the maximum amount of your local anesthetic, it is better to be observant to your patient. Note if there is any unusual manifestation of your patient, like lightheadedness or sedation, restlessness. So it is when you give local infiltration, most especially if you have given already the maximum, it is best to be conversant to your patient, because the way that the patient will answer, if the patient will have slurring of speech, it is one manifestation that you are getting near local anesthetic toxicity. So here is your cardiovascular effects, which comes next. So all local anesthetics are vasodilators except for cocaine. So patients with pre-existing cardiovascular disease may develop heart block and other disturbances of cardiac electrical function at high plasma levels of your local anesthetic. So first, the manifestation, if you have a patient now having local anesthetic toxicity in your cardiovascular, first, the patient may have hypertension or tachycardia because the patient also becomes restless. So restlessness, the patient will have an increase in your blood pressure, increase in your heart rate. Then, after all this manifestation, if there is no intervention with your patient, then there would be a decreased contractility and cardiac output, then hypotension sets in. Next, there would be sinus bradycardia, ventricular dysrhythmias, then circulatory arrest. So, your circulatory arrest result from the selective blockade of the inhibitory pathways. So, that would be your cardiovascular manifestation. So, when cocaine is used as a drug of abuse, cardiovascular toxicity includes severe hypertension with severe cerebral hemorrhage, cardiac arrhythmias, and myocardial infarction. So that your cardiovascular toxicity would manifest as hypotension, the late manifestation, cardiovascular manifestation of local anesthetic toxicity would be hypotension, conduction blockade, and cardiac arrest. So, other toxic effects. The ester type of local anesthetics are metabolized to products that can cause antibody formation in some patients. So, with regards to the ester group of your local anesthetic, its metabolism, one of its metabolites is para-aminobenzoic acid, or your PABA. So your para-aminobenzoic acid is said to be the one that is responsible for the hypersensitivity reaction from your ester group of your local anesthetic. So there are times that lidocaine, which is an amide local anesthetic, would produce hypersensitivity reaction. This is when your lidocaine is in a multi-dose vial. But nowadays, you can seldom say multi-dose vial of lidocaine because most of the lidocaine now comes in polyampule. So at 5 cc, in one ampule contains 5 ml. Unlike before, that your multi-dose vial of lidocaine, there are 25 cc, 50 cc. So you cannot consume it in one setting. So there is a preservative in this multi-dose vial, which is known as methylparaben. Methylparaben is related to your para-aminobenzoic acid, and this is the one that is responsible for a hypersensitivity reaction with the use of lidocaine in a multi-dose vial because of the preservative methylparaben, not because of lidocaine. So In high concentration, local anesthetic may cause a local neurotoxic action that includes histologic damage and permanent impairment function. You have your so-called transient neurologic symptom. Your transient neurologic symptom, this manifests in the form of moderate to severe pain in the lower back, buttocks, and posterior thigh. So these symptoms appear within 24 hours of spinal and epidural anesthesia and generally resolve within 7 days. That is why it is known as transient, because it resolves within 7 days. This is usually the causative anesthetic is usually this is lidocaine. Lidocaine is the one that would cause transient neurologic symptom or your TNS. So we come now to treatment of anesthetic, local anesthetic toxicity. So with regards to your treatment of your local anesthetic toxicity, it is very important to first to be aware that you are not giving a high concentration of your local anesthetic, thus resulting in an elevated plasma level, or else the giving of your local anesthetic intravascularly. So with regards to your last or your local anesthetic systemic toxicity, this is best managed by preventing the occurrence of toxic plasma levels of your local anesthetic by using the minimum effective dose. Minimum effective dose required for specific regional anesthetic technique. So that very important is the vigilance for an inadvertent direct intravascular injection and be aware of the early signs and symptoms of blast. So this is the thing that you should remember. Vigilance for an inadvertent administration of your local, inadvertent intravascular injection of your local anesthetic, and be aware of the early signs of local anesthetic systemic toxicity. This is the best management. To prevent the occurrence rather than to treat it when it is already there by preventing the occurrence of toxic plasma levels. So be aware to use the minimum effective dose for a specific regional anesthetic technique. So severe toxicity is treated symptomatically. So symptomatic, the treatment is said to be symptomatic and support to the patient. The very important thing that you should remember in treating is you should have a good airway. You should have an adequate oxygenation of your patient, and the airway must be patent. So support the airway. The first thing that you should do is to support the airway, and then the cardiovascular system. So if there is hypotension, you have to treat the hypotension. If there is bradycardia, then you have to treat the bradycardia of the patient. So with regards to convulsions, and we say that the manifestation of your local anesthetic toxicity is seizure. Of course, there is still the early signs like lightheadedness, your restlessness, nystagmus, perioral numbness. These are early signs. But the late signs, the later part of the toxicity from your local anesthetic is seizures. And then you have convulsions. So if you have convulsions are usually managed with intravenous diazepam or a short-acting barbiturates such as your thiopental. So, by the way, if you notice that your patient has already early signs of CNS toxicity from your local anesthetic, then by all means, you have to stop the administration of your local anesthetic immediately. Then proceed to adequate ventilation and oxygenation. It should be maintained and the airway must be secured. So if there is now convulsion, then it is usually managed with intravenous diazepam or a short-acting barbiturate such as thiopental. Or you can also use propofol because we have mentioned yesterday that propofol has an anti-convulsant effect. The convulsions, you can give either diazepam or short-acting barbiturates or propofol. But the disadvantage, the drawback of using barbiturates and propofol for stopping the convulsion is that at the same time they cause hypotension. An hemo patient is already hypotensive because of the effect of your local anesthetic. So when you give your barbiturates or your thiopental or your propofol, then you also produce hypotension. So the best drug to use for convulsion is your diazepam. Diazepam being a mild cardiovascular depressant, it doesn't cause so much hypotension. So diazepam is the ideal or the effective drug to stop convulsion. If you are to choose, you have diazepam, you have barbiturates, you have propofol, then you have to choose diazepam. But you can use any of this. In the absence of diazepam, you can use barbiturate. You have no choice. You can use barbiturates and thiopental or propofol, but be sure, as I have said, you inject your propofol slowly so that you will not have a more profound hypotension. So you have your diazepam. Hyperventilation with oxygen is helpful. When we come to hyperventilation is considered because when you hyperventilate your patient, it would decrease your PaCO2. So when you decrease your PaCO2, you decrease your cerebral blood flow, thereby decreasing the delivery of your local anesthetic into the brain. By the way, the importance of you have to stop convulsions because when your patient goes into convulsion, your patient goes into respiratory and metabolic acidosis. Convulsion causes respiratory and metabolic acidosis. And acidosis, respiratory acidosis, metabolic acidosis would exaggerate the effects of your local anesthetic toxicity. So that is very important that local induced seizure activity should be stopped because it can vastly increase the body's metabolism. Diba? If you are in convulsion, your body metabolism increases, and this results in metabolic acidosis that may make resuscitation more difficult for local anesthetic toxicity because you aggravate metabolic acidosis aggravates local anesthetic systemic toxicity. So that is the importance of you have to stop convulsions. Occasionally, when, for example, you have already given your anticonvulsants like diazepam, your barbiturates, or your propofol, but yes, the patient continues to be convulsing. Then you have to give a neuromuscular blocking drug to control the violent convulsive activity, like, for example, succinylcholine. But neuromuscular blocker can stop the peripheral manifestation of seizure activity, but not the underlying CNS activity. So it is as a last resort, just to stop the convulsion, because if the patient is convulsing, we say that we have to stop the convulsion. So we have to give your neuromuscular blocking drugs, but this is not the ideal one to give to stop convulsion. It is diazepam, because your neuromuscular blocking drug can only stop the peripheral manifestation of seizure activity, but does not treat the underlying CNS activity, unlike your diazepam or your barbiturates or your propofol. But again, as I have said, your barbiturates, your propofol can cause profound hypotension. So it is diazepam. If you have diazepam, that is the most effective. So we have now the commonly used local anesthetics and their application. So you have Articaine, approved for use in the United States as a dental anesthetic, generally considered to be more effective and possibly safer than lidocaine. So you have benzocaine. Benzocaine has a potential to induce methemoglobinemia. There is another local anesthetic that can cause methemoglobinemia, which we will mention later. It is prilocaine. So you have bupivacaine. Bupivacaine is one of the long-acting amide local anesthetic, avoided for techniques that demand high volumes of concentrated anesthetic because of its cardiotoxicity. So with regards to bupivacaine, your bupivacaine is marketed as a 0.25%, 0.5%, and before it has 0.75%. But now the only available concentration of your bupivacaine is 0.25 and 0.5%. 0.75% has been taken out from the market because of its high incidence of cardiotoxicity. 0.75% can give you a very good muscle relaxation, but the drawback is its high incidence of cardiotoxicity. So that we avoid bupivacaine, we do not now use bupivacaine at 0.75%. Bupivacaine is one of the local anesthetic that is used for differential blockade, most especially for labor analgesia and obstetric anesthesia. When we say we give your bupivacaine as a differential blockade local anesthetic, because if we want only labor analgesia, we give half of your 0.25% bupivacaine, which is 0.125. So 0.125 to your 0.25%, this is given for analgesic effect, most especially for labor analgesia. But if the patient will undergo cesarean section, then we have to use now your 0.5% concentration of your bupivacaine, because you want now motor block. So when you have your so-called differential blockade, you want to separate your sensory block from your motor block. And the anesthetic for this, not all anesthetic would produce differential blockade. So one local anesthetic that has differential blockade is your bupivacaine, because you can separate your sensory from your motor block by using different concentration. So when you want only analgesia, you give your 0.125. You start first with your 1.25. Then you can give as high as 0.25 for analgesia. But you do not have motor block. When you want motor block, you have to give your 0.5%. That is why your 0.75% bupivacaine has a very good motor block or muscle relaxation, but the drawback is its cardiotoxicity. So, at relatively low concentration, less than 0.25%, these are frequently used to achieve prolonged peripheral anesthesia and analgesia for post-operative pain control. For post-operative pain control, you can also use this concentration, 0.125 to 0.25%. So, bupivacaine is often the agent of choice for epidural infusion used for post-operative pain control and for labor analgesia. So with regards to chloroprocaine, this gained widespread use as an epidural agent in obstetric anesthesia. It undergoes rapid hydrolysis and serve to minimize the risk of systemic toxicity or fetal exposure. But at high doses, chloroprocaine is capable of inducing neurotoxic injury. Now we have cocaine. Current clinical use of cocaine is largely restricted to topical anesthesia for ear, nose, and throat procedure. Because when you use cocaine topically, because of its vasoconstrictive property, it decreases bleeding. So that is one advantage. When you have surgery at the ear, nose, and throat procedure, because of its vasoconstriction, it would decrease bleeding. So actually, cocaine, being the first local anesthetic, this has been discovered by Dr. Carl Kohler. Dr. Kohler is an ophthalmologist, and he noticed the anesthetic effect of cocaine. When he instilled cocaine into the conjunctival sac, he was able to produce numbing effect of the cornea. So that is the first being used. Your cocaine is used clinically as a topical anesthetic of the eye by Carl Kohler. So that is why Carl Kohler is considered to be the father of local anesthesia, because he was the one who first discovered the first local anesthetic, which is cocaine. Now, the drawback now, this is not being, it is said here that it is largely restricted to topical anesthesia for ear, nose, and throat procedure, no longer on the eye. Why? Because of its potent vasoconstrictive effect, it causes drying of the cornea. So when cornea dries, it is easily becomes abraded. So it is not being used on the eye anymore. Etidocaine has had limited application due to it. Etidocaine is another amide local anesthetic. Cocaine is an ester local anesthetic. Has had limited application due to its poor black characteristic. Has a tendency to produce an inverse differential block. When you say an inverse differential block, because the usual differential block proceeds from autonomic, sensation, sensory, and motor. And the recovery from the black is it would start on the motor, sensory, and autonomics. So reverse with regards to recovery. As to the onset of local anesthetic effect, it starts on the autonomic, sensory, motor. But the recovery, motor recovers first, sensory, then autonomic. So this inverse differential block, meaning to say that instead that the motor block would be the one to recover first, it is the sensory. So it is known as an inverse differential block. So that is why it has a limited application, because the sensory blocks wears off earlier than the motor block. So you have levobupivacaine. Levobupivacaine is related to bupivacaine. But the difference is that your levobupivacaine, although they produce the long duration of action, but it is less cardiotoxic than the racemic mixture. It is less potent and tends to have a longer duration of action. The magnitude of this effect is too small to have any substantial clinical significance. It has the same action, but less cardiotoxic. Its clinical profile of levobupivacaine, the S isomer, is essentially the same as the racemic bupivacaine, except that somewhat it has a wider therapeutic index, meaning to say when you have wider therapeutic index, it is more safer because of a less cardiotoxicity and systemic toxicity. So lidocaine, another amide local anesthetic, it has a high incidence of developing transient neurologic syndrome with spinal anesthesia. And usually your transient neurologic syndrome is more common if the position of the patient is in lithotomy position and the patient is obese. So excellent record as an intermediate duration anesthetic remains the reference standard against which most anesthetics are being compared. So lidocaine remains to be the gold standard by which your other anesthetic is being compared. So mepivacaine. Mepivacaine, another intermediate amide, displays clinical properties that are comparable to lidocaine. But it differs from lidocaine with respect to vasoactivity, as it has a tendency toward vasoconstriction. So, popular choice, mepivacaine is popular choice for major peripheral blocks because of its highly longer duration of action. So, I have said that mepivacaine is another intermediate acting local amide local anesthetic, and mepivacaine is another intermediate acting local anesthetic. But it says here that popular choice for major peripheral block because of its slightly longer duration of action than the other intermediate like lidocaine. Because lidocaine is a more potent vasodilator. It is your lidocaine is more potent vasodilator than mepivacaine. So being a potent vasodilator, absorption is said to be rapid and metabolism is also rapid, so that it results to a shorter clinical blockade than that produced by prilocaine or mepivacaine. So prilocaine, mepivacaine, and lidocaine, they are all intermediate acting local anesthetic. But since local anesthetic is more potent vasodilator than mepivacaine and prilocaine, so it would result to more rapid absorption and metabolism, resulting to a shorter clinical blockade. Slowly metabolized by the fetus, poor choice for epidural anesthesia in the parturient. So here now is prilocaine, another intermediate amide local anesthetic. Highest clearance among the amino-amide anesthetics, imparting reduced risk of systemic toxicity. But this reduced risk of systemic toxicity is somewhat offset by its propensity to induce methemoglobinemia. So the methemoglobinemia from prilocaine results when you give prilocaine at a dose greater than 600 milligrams. So high dose of prilocaine greater than 600 milligrams would result to methemoglobinemia. So results from accumulation. The methemoglobinemia results from the accumulation of one of its metabolites, which is orthotoluidine. And your orthotoluidine tends to oxidize hemoglobin to methemoglobin. So it is an oxidizing agent that oxidizes hemoglobin to methemoglobin. So the dose greater than 600 milligrams can produce clinical methemoglobinemia, making the patient appear cyanotic. So, but this methemoglobinemia is said to be transient because this condition is spontaneously reversible or may be treated by IV administration of methylene blue at a dose of 1 to 2 milligrams per kilogram. You have ropivacaine, another long-acting amide local anesthetic. Another drug, another local anesthetic that displays differential block. So popular choice for epidural infusion for control of labor and post-operative pain. This is a new amide local anesthetic that is structurally and behaviorally similar to bupivacaine. Like bupivacaine, it is highly protein bound and has lengthy duration of action. However, it is less cardiotoxic than bupivacaine. So, capable again of providing differential blockade since it is capable of separating sensory and motor blockade. So, because of this characteristic, it makes ropivacaine also an ideal anesthetic for use in obstetric procedure. So, you have now EMLA. This is cream. This is EMLA stands for eutectic mixture of local anesthetics, which consists of 2.5% lidocaine and 2.5% prilocaine. This permits anesthetic penetration of the keratinized layer of the skin. So in other words, this is a form of dermal analgesia that would require a contact time of at least 1 hour under an occlusive dressing. And this is commonly used in pediatrics to anesthetize the skin prior to inserting an IV line. So this is your EMLA. And this should not be used on mucous membrane. It should not be used in broken skin. And it should not be used in infants less than 1 month old and patients with predisposition to methemoglobinemia, because a prilocaine may cause also methemoglobinemia because of prilocaine. So patients with predisposition to methemoglobinemia should not be given this IMLA. So that ends our lecture. But before we end our lecture, I would just like to mention about basic pharmacology, because our local anesthetic in solution exists in equilibrium as an ionized and a non-ionized form. So meaning to say, your local anesthetic molecule, there is at equilibrium, it exists as an ionized and a non-ionized form. And the non-ionized form is the lipid soluble form, while the ionized is the water soluble form. So that in our diagram with regards to local anesthetic molecule, wherein you have an aromatic benzene ring, which is the head portion of your local anesthetic, that is the lipid soluble form of your local anesthetic, while your hydrophilic is the amine group of your local anesthetic. So I would just like to emphasize that the non-ionized, it has a role in this ionized and the non-ionized form. It has a role in your local anesthetic molecule, because the non-ionized form, which is considered to be lipid soluble, is the one that would cross the axonal membrane. So being lipid soluble, it is the one that is responsible for the crossing of your local anesthetic into the axonal membrane, while your ionized or your water soluble, this is the one that is responsible for the neural blockade, because this is the one that would act with your voltage gated sodium channel. I have forgotten this, the mechanism of action, by the way, of your local anesthetic. Your local anesthetic block voltage dependent sodium channels and reduce the influx of sodium ions. So this is the electrophysiologic effect of your local anesthetic. The direct inhibition of your local anesthetic on the voltage-gated sodium channels, so that this interaction being initiated by the binding of your local anesthetic molecule with the receptor that are found in your sodium channel would result to the prevention of your sodium influx. So the binding of your local anesthetic with the receptor in your sodium channel would reduce or prevent the influx of your sodium ions, which is important for the initiation and the propagation of action potential. So very important. Voltage. So the mechanism of action of your local anesthetic is direct inhibition of the voltage-gated sodium channel, so that the interaction between the binding of your local anesthetic with the receptor in the sodium channel would prevent the influx of sodium ions, which is important for the initiation and propagation of action potential, which we say that your local anesthetic prevents the conduction of nerve impulses, conduction and propagation of nerve impulses. So it is here I have mentioned that both the non-ionized and the ionized forms of the drug play an important role in your local anesthetic. The drug molecule must cross the lipid membrane to reach the cytoplasm. So what is responsible for the drug molecule to cross this lipid membrane? It is the non-ionized portion or the lipophilic portion of your local anesthetic. So the more lipid-soluble form reaches effective intracellular concentration more rapidly. So once inside, now the axon, the ionized form of the drug now comes into play. It is more effective blocking entity. So it is the ionized water-soluble portion of your local anesthetic that is responsible for neural blockade, because this is the one that would interact with your voltage-gated sodium channel. So that is what I forgot to emphasize. By the way, back into basic pharmacology, your lipid solubility, protein binding, and degree of ionization is very important with regards to the activity, pharmacologic activity of your drug. So, when we say lipid solubility, what does this correlate? Anybody? What does lipid solubility correlates? Lipid solubility correlates to
the onset, Doc.
lipid solubility. So these three characteristics of your drug, lipid solubility, protein binding, and degree of ionization, is very important because lipid solubility would determine potency. So lipid solubility determines potency. The more lipid soluble a drug is, the more potent it is. So that is why in local anesthetic toxicity, the more lipid local anesthetic, the more tendency that it will produce toxicity. Just like your bupivacaine, more lipid. So lipid solubility would indicate potency. How about protein binding?
Distribution, Doc.
So, distribution.
If for example, Doc, more protein bound yung drug, yung onset of effect is delayed kaya hindi siya maka-penetrate sa organs na target.
So, onset of effect is delayed. How about the duration of action?
If more protein bound, Doc, the duration is delayed din, Doc.
You have a longer duration of action when a drug is protein bound. longer duration. So in other words, protein binding would correlate to the duration of action of your drug. So the more the drug is bound to your plasma protein, the longer the duration of action. While the onset of effect would correlate to your onset of effect. It would tell you about your degree of ionization. So, degree of ionization, whether your drug is unionized or ionized. So, a drug to be pharmacologically active should have the following property. Ano man?
Lipid soluble, Doc.
A drug to be pharmacologically active should be
Lipid soluble.
lipid soluble. Ano pa?
Non-ionized.
Unionized or non-ionized. And the last one, it should be unbound. So, three characteristics that would make a drug pharmacologically active. It should be unionized, lipid soluble, and unbound or not protein bound. So that is why when you have an acidic environment in the presence of infection or abscess, it makes your drug highly ionized so that your drug doesn't have good effect. Ang itong purpose. If you have infection or in abscess formation, you have an acidic environment. So it makes your drug to be highly ionized. So that is why your drug does not have a very good effect. So pharmacologically active drug must be lipid soluble because it can cross easily your bilipid layer of your cell membrane. It must be unbound and it must be unionized. Okay. Any question? Any other question? An important is toxicity. Toxicity from your local anesthetic is very important. So, by the way, another thing to remember that if you have to give a higher concentration or volume of your local anesthetic, it is better to premedicate the patient with benzodiazepine because benzodiazepine tends to increase the threshold, seizure threshold from your local anesthetic. It raises the seizure threshold from your local anesthetic, your benzodiazepine. Okay. No more questions. So, okay, if there is none, then we end up to this point. Thank you.
Thank you, Doc.
Thank